Hello, everyone. Welcome to Freedom Talks. This is Brady, and today I'm here with Dr. Mustafa Khan. He is an American board-certified orthopedic surgeon specializing in spine surgery. He's passionate about getting to know his patients' health goals so he can help them achieve optimal function and freedom from pain. And as well, I'm also joined by physical therapist Erin Bafunno. She is a physical therapist at Freedom Physical Therapy who's also passionate about helping patients move with freedom and restriction from pain. How are both of you guys today?
We're good. Thank you for having me.
Yeah, of course. So, Dr. Khan, getting kind of right into it, we kind of want to get to know you and get to know your kind of philosophy on healthcare and what you've been doing. And also, you've started a very exciting YouTube channel trying to educate patients and people about spine surgery. So, we're glad to have you on. And can we kind of start with your background and your education, and then how you eventually became very passionate about spine surgery?
Sure. Thank you for having me, Brady. The process of becoming an orthopedic surgeon is a very long process. I undergrad went to University of Minnesota and went to med school at University of Pennsylvania in Philadelphia. And I did my residency at the University of Pittsburgh. And I finally finished up my spine surgery fellowship at Rush University in Chicago. I've been in practice since 2008, so I've been in practice for about 15 years. And my surgical interests are adult spine surgery of all kinds. So basically, patients who have any kind of a cervical, lumbar, or thoracic spine problem, includes herniated discs, spinal stenosis, sciatica, and things of that nature. But the one thing that I always tell my patients is that 90% of the patients who come and see me end up not needing surgery. So even though I am a surgeon, my job involves taking care of patients, not only surgically, but also in helping them get to the right physical therapist, get the right non-operative treatment. So that, in summary, is my background and training.
And so, were you drawn to the spine, I guess, as your specialty as you kind of moved through the med school and residency processes? What drew you to that?
So that's an excellent question. I did my residency at University of Pittsburgh Medical Center, which is one of the country's most premier orthopedic residency programs and orthopedic teaching programs. And it just so happened that my mentors at University of Pittsburgh were fantastic in the spine department, and they just became like a great source of inspiration for me. And I saw firsthand how much they were able to help their patients with some very severe spine problems, which includes not just arthritis and disc herniations, but we also did a lot of trauma work, people who are involved in car accident, falls, other types of injuries. So during my residency of 6 years, where I also did a whole lot of research, I was able to see how much we were able to help patients with some very severe spinal problems. And as I progressed through my residency, I slowly began to understand that, you know what, this is something that I could be interested in. And eventually that's what I ended up doing. So that's how I ended up in spine surgery, because you can really make a big difference in the lives of people in all across the spectrum of society, of all ages, of all professions, and really give them a meaningful improvement.
So just curious about some of those, like you mentioned, that Pittsburgh Health Center being one of the premier hospital systems in the country. Was there anything in particular that stood out to you that was either jarring or fascinating from your perspective, coming from where you did med school and your previous experiences, and that kind of have stuck with you through coming back to Wisconsin?
So when you train at any institution, for example, I started my medical training at University of Pennsylvania in Philadelphia. Each hospital system has its very distinct culture, and it's sort of like an individual. It's got its own personality. And then when you move to a different hospital like University of Pittsburgh, that too has its own distinct personality. So comparing the two hospitals and the different types of training that you get at either one of those places, it kind of adds to your life in a different way. So Med school at University of Pennsylvania was very, very competitive. It was very challenging and taxing. And residency, similarly at University of Pittsburgh, we were extraordinarily busy. We used to work well over 100 hours a week. And in the third year of my residency, we cut down from 100 plus hours of working a week to a maximum allowable of 80 hours a week. And that's where things stand right now. So when I started my medical and surgical training, it was sort of like baptism by fire, but you kind of get used to it, and that makes you very disciplined, that makes you very motivated, that makes you very efficient, that makes you very confident, and that allows you to handle things very rapidly and to kind of like assess a big problem very quickly and get to some good real life solutions. So I think the whole process of becoming a doctor in general and a surgeon in particular, it's a very difficult process. And as you're going through it, sometimes you wonder and you ask yourself, am I doing the right thing? But once you kind of get through that process and you come out on the other side and you kind of catch your breath, you start your practice, you realize that it was worth it, because time is going to pass regardless of what you do in life. It's just a question of doing the right things and getting to a destination where, you can make a difference in other people's life and you can become a better person at the end of it. So I think even though my training process, just like any other orthopedic surgeon or surgeon in general, was very difficult and very challenging, I think it made me a better person. It made me a better human being and certainly a better surgeon.
That was a great answer. That's amazing. And I imagine, like you said, baptism by fire is a little bit stressful when you're working 100 hours a week and getting everything thrown at you. And so kind of you went from there and kind of moved back to the Wisconsin area directly after that. Is that correct?
So after that, I was at academic practice. I practiced at the University in Ohio, and I've been in the Milwaukee, Wisconsin area for about 5 years. I came here in 2017. So okay. Now I'm in private practice and I moved away from academia.
And was that always the intention for you, is to move into private practice away from academia, or was there something that you were like not pleased with in academia, or you had simply done what you wanted to do in that spot?
The advantage of being in academics when you're young is that you get to see a lot of very difficult surgical problems that you would not see in private practice. So being in that very tough environment where you're taking a lot of calls, doing a lot of very difficult cases that nobody else wants to do, it gives you a lot of experience, a lot of confidence. And I think from there, it's a very nice and natural transition to move into private practice. So it was not really planned, but that's how it turned out. And actually, I think it worked out for the best.
And so kind of moving into your private practice and what you're doing now, you had mentioned earlier about being able to affect large groups of the population and kind of seeing all of the groups of the population in some way, shape, or form with patient populations. So who are you, currently seeing, and kind of what are you really excited about in terms of your current practice?
So that's a very deep question, which has many components to it. So I see mostly adults, although I do see some older teenagers. For example, I see a lot of, young athletes, high school athletes, 16, 17, 18-year-olds with, back and neck problems, and all the way across, the next several decades. I see people who are in the 70s, 80s, and even 90s. So each age group has its own particular set of challenges and problems that you need to consider. For example, if you're a teenager or in your early 20s, a lot of those patients are very, very active. They have a very high physical demand. Whereas patients who are in their 60s, 70s, 80s, and 90s, as time goes on, their activity level and their demands and their own expectations are significantly less. So I see a whole spectrum of different ages with very different problems within each age group. And that's what makes my job very interesting and challenging.
And Erin, I think a little bit you're kind of seeing that broad range of patients as well. We're not necessarily a sports specific physical therapy place or a kind of geriatric physical therapy place we see across the whole population. What has your experience been working with a lot of the spine patients and having to communicate with doctors like Dr. Khan when you're in your practice?
So one of the most interesting things about treating like a very broad age range, so just kind of like Dr. Khan mentioned, is treating people from the age of 12 to into their 90s of various back-related, neck-related issues, is managing expectations. So that's, I think, truly the biggest piece. Is the majority of people that come in, if they have a disc-related issue or they have a spinal arthritic-related issue, so many people have some preconceived notion of what they've read online, or they heard someone say that they had a back problem once and then they were disabled and couldn't go to work. And so I think the big thing in terms of managing expectations, preconceived notions, things they've learned from other people, is actually the biggest hurdle, because one of the highest things that we see is fear-based anything in terms of spine pain. Is once you have spine pain once, again, most people know someone that has had an associated issue, and whether you couldn't go to work one day or you had trouble lifting your children, or it doesn't have to be you become disabled and can't do your job for the rest of your life. It can be multiple things, where you even missed a family vacation because you couldn't get off the couch because your back hurt so bad. So teaching people how to understand what pain is, how to manage it, when to know when to take a step back, but those step backs mean different things. So in a 16-year-old soccer player that has a muscle strain, that's very different than maybe a 30-year-old that has a disc-related problem. So all those step backs can mean very different things for different age groups, and can mean very different things based off of their own personal history of back pain.
So it sounds, at least from my perspective, that kind of misconceptions and perception of different care is greatly going to affect treatment. Now, when you're talking about managing those specific expectations, and do you find that there's a lot of maybe misinformation that you have to combat? And it sounds like a lot of patient education coming from both of you that is big for your patients, correct?
Yes. So like one of my biggest, say, pet peeves is when people come in and say they blew a disc. So, and it's just my own personal pet peeve. Everybody has their own thing, but when we injure a disc, which Dr. Khan will know a little bit more in detail than I do, just because he's seen them inside the body, which I can say I have not. But when you say you blew a disc, it has such a negative connotation to it. Like you picture it blowing up, and essentially in a form that is kind of what's happening. But once you think of something blowing up or it blew, you have such a negative view in your mind that like, I can't come back from this. And I think that's one of those biggest hurdles. People are like, I can't move. And then they start moving like a stick. They are holding their breath every time they move. They're not twisting, they're not moving. And some of that we do want patients to hold off in the beginning, just to let their body calm down and heal. But the sooner we can restore some level of normal motion, again, within some limits, and teaching them how to modify their activity based off of that is so important to know. And I'm like, you injured a disc. Your discs can heal. It's not one part of our body that can't. Some people, it maybe doesn't heal as well as other people. But understanding that just because it blew, it didn't blow up and it's gone forever. You still have a disc, it's still there, it can close up, it can partially heal. But understanding just because it's injured once doesn't mean it's going to be gone forever.
Dr. Khan, specifically when it comes to disc herniations, I know I was looking at some of the images that you had on your website. Something you obviously deal a lot with. Do you find some of the same misinformation with patients, or specifically when it comes to disc herniation? Like how does a typical appointment go? And like you said 90% of your patients don't actually go to surgery for you. So I guess in which cases are they going to be a surgical candidate, and in what other cases are you going to take a different approach?
So I just want to say that Erin basically stole my thunder, and she basically said everything I was going to say about it. So first of all, I agree with Erin, what she said. Before talking about particular spine problems, I think my first job as a physician and also as a surgeon is to educate my patients, right? So before you can talk about how to fix a quote unquote disc problem, you have to understand what the disc is and why it's important, what the function is, what are the biomechanical considerations of the spine, right? So you have to kind of understand all of these things before being able to evaluate a disc that's not functioning properly, or that's herniated, or that's degenerated. And then you have to kind of take the next step of how do you make that problem better, either with physical therapy or with medications or injections. So what I would add to what Erin already talked about is that there's a lot of fear amongst people when they injure their back. And that's totally understandable. Back pain, it can be very debilitating. Spine problems can be very debilitating. And when somebody has a back problem, they ask around, they get a lot of different answers and suggestions and stories from people that they know, either at work or personally, that give them a lot of information, which unfortunately turns out not to be true. Where you see that a lot is, for example, with things like, a sciatica, which is probably the most common example. Patients, when they come and see me for severe sciatic symptoms, for example, these people can't walk, they can't drive a car, they can't go to work, they can't take care of their little kids. Basically, their whole life is turned upside down. But when I send them to physical therapy, give them a little bit of short course of anti-inflammatory steroids, give them some muscle relaxers, or maybe even give them an epidural injection, 2 weeks later, their life is turned upside down for the better. So just like Erin said, there's a lot of misinformation. And as a physical therapist, as a surgeon, as a physician in general, your number one, the first thing you have to do is to educate your patients about what is the problem that you're dealing with, what is the prognosis for the majority of patients, and how we can help you get from here till there.
And then I'm just a little bit curious as to, currently in your practice, is there a certain surgery that you find yourself doing? Like the majority of cases, you're doing fusions or discectomies or disc replacements, or what is it currently that is or is it just a broad range and there's not one specific surgery that you find yourself doing?
So there's a broad range of surgical cases that I do. And I would say that for any, practicing spine surgeon in the community, on average, 2 out of 3 surgeries are on the lower back, on the lumbar spine. About 1 out of 3 surgeries is the cervical spine. So that's roughly a ratio which probably will hold true for the vast majority of surgeons. When it comes to the cervical spine, the most common surgeries that I will do will be the anterior cervical discectomy and fusion. That's for patients who have a pinched nerve in the neck causing shooting pain going down into the arm. And we go in and we remove that degenerated disc, we unpinch that nerve, and we stabilize the spine with a plate and screws. As far as the lumbar spine is concerned, the 3 most common surgeries are discectomies, where we just kind of go in and take a small piece of the disc out through a minimally invasive approach. The second is what's called a laminectomy, where we make a bigger incision and do a more involved decompression and free up the nerves at multiple levels. And the third one is where the situation needs something a little bit on a higher level, where we do the laminectomy with a fusion, where we have to stabilize the spine by fusing it using some hardware, rods and screws. So those are on an average day, average week, average month, and average year. Those are the most common surgeries that I do in my practice, which I think is probably very similar to most surgeons in the community.
So I guess I think what would be beneficial for patients or potential patients or someone who's dealing with spine issues to kind of hear is maybe the process that a patient would go through, to eventually see you and get diagnosed and do all of the testing, but maybe what it's like to go in for an evaluation, and then also maybe when is physical therapy involved, or what other types of healthcare treatments are involved with most of your patients?
So to get an appointment with me, you can get my contact information at my website, mustafakhanmd.com, and you can just call the number and I'll be happy to schedule you at any time if you have any kind of back problem or neck problem. And what's interesting is that the vast majority of patients who come and see me with neck and back problems, they already have an established relationship usually with a physical therapist, because they either had a knee problem or a hip problem or a shoulder problem. And when I see that patient, I will usually send them back to their physical therapist that they've worked with and prescribe them some medications, and then see the patient back in a couple of weeks for a follow-up. If they're doing well, we just sit tight and just kind of see how things go, maybe adjust the medications a little bit. But if they're still having problems, the next step usually is to get an MRI. And based on the MRI, we can just either sit tight, see how things go, or try some cortisone or epidural injections. But if the problem is quite severe and is still not getting better, then we can talk about a surgical option as the next step.
And then post-surgery, what are the, like, I guess maybe even if it's a question for Erin, like, what patients are you seeing pre or post-surgery for spine? I guess pre would be like someone that you see and then you're referring to Dr. Khan and saying, hey, look, I think this is more than, some muscular issues or something that you can correct. And that you need to get help from an orthopedic surgeon. And then who are you generally seeing for rehab? Like, is it the fusions? Is it the discectomies? Is it all of the above? Does that make sense?
Yep. So in terms of pre-surgical patients, like I would say the majority, most therapists would probably say this, I'd say anywhere from 50 to 75% of your caseload is probably someone that has some form of a low back related issue. It's just one of the most heavily diagnosed or heavily used diagnosis codes that we see. So most therapists at least should have some general ability to be able to treat a low back or cervical related issue, just because it is unfortunately very common. So in terms of preventative, I like to generally see a patient's reduction of pain within 2 weeks. If I have not touched the patient's pain at all in 2 weeks, then at that point I'm referring, because something at that point we should have done should have made an improvement. And if there's been absolutely no change, and especially if there's any nervous system involvement, that's also when it becomes a little bit more concerning. So I'm also addressing strength, looking at strength deficits, looking for numbness and tingling. Does the patient have any sensation? If we start to notice any complete loss of sensation, they might have numbness and tingling. But if there is absolutely, they cannot feel me touching their foot, can't feel me touching their leg, that's when I'm immediately referring for those situations, because then we have more potential for nerve damage that's not reversible at that point. When we talk about peripheral nerves, those are the nerves that are not outside of your spinal cord. Those have the option. They have the ability to regenerate, but if they've had too long of compression or irritation to them, they might regenerate a little bit, but then a patient could potentially have those issues for a really long time. So at that point, that's not something I like to mess with or do a wait and see. That's when that becomes more of a Dr. Khan territory than my own, because I would want someone to do the same thing for me. As I'm not going to just keep blindly treating someone hoping that they'll get better. I would like to have them get seen sooner rather than later. And some of those medication options that Dr. Khan mentioned, like any sort of an oral steroid or a muscle relaxer, when they're utilized the correct way and they work the way they should, usually within 3 to 5 days, the patient's pain is cut in half, again, when it works the way it should. And at that point, we're working on establishing better movement patterns. If someone's in a lot of pain, they're, again, not moving the right way, again, holding their breath. And when you hold your breath, it actually gives you more pain. And so it makes it harder to move. So trying to reestablish some newer patterns like that. But biggest red flags, like I would immediately send for in the clinic, would be if anyone's having bowel or bladder issues. So if a patient comes in and you can't hold urine, or if you can't hold it or you can't go, if you can't eliminate or evacuate both bowel and bladder, that's a huge concern. Any numbness or tingling, we call it the saddle region. So that's in between your thighs and your groin region. And then bilateral. So both leg numbness and tingling, those are the things that I'm actually sending them that day. I've not seen them. I'm not finishing my evaluation. They're out the door because that becomes more of an emergent situation. Not as common, not very often, but those are things that are well beyond my territory. But patients that have general run-of-the-mill low back pain, whether it's muscular in nature or joint-related irritation, we try to find where their problem lies. Do they have problems with sitting, or is it standing? Because that tends to tell us a little bit more of what structures are involved and how we can, again, modify daily activities and then start to encourage some strength-based options. We utilize dry needling techniques at our clinic to help restart the inflammatory process. So if someone is outside of the first 2 to 4 weeks of an acute issue, We utilize dry needling. It can help increase some blood flow to the area, flush out some of the inflammatory toxins, and kind of help, I call it the control-alt-delete for your muscles. It just kind of restarts them, lets them reset, and allows your body to develop some better movement patterns. So that'd be more pre-surgical. And then in terms of post-surgical options, really, I would not say we'll see anybody, but as long as the doctor has okayed it and approved it and it has some idea of a protocol, or if they say go for it, do whatever you want and you feel comfortable with, then that's also an option. We generally have lifting restrictions depending on the surgery for anywhere from 6 to 10 weeks afterwards, just as we're letting bone parts heal if there's some sort of a fusion. Range of motion, we do it generally within comfortable levels. And again, mostly working on mechanics, is someone's likely been lifting wrong their entire life. And everybody's like, oh, lift with your legs, but they might still be lifting with their back despite trying to lift with their legs. So again, working on more functional daily tasks. Scar mobilization is a huge option. So even if some of the procedures are minimally invasive, the scars can get really bound down, and that can limit your overall skin flexibility, which also affects muscle flexibility. So soft tissue work, incisional mobility, but generalized strength training, and trying to, again, figure out what is the hardest thing for the patient to do at home and trying to help them find a way to do it better, easier, and with less pain. Long answer, sorry.
So Dr. Khan, I guess I am curious of, I guess, almost your opinion of physical therapists. And just like in anything, there's better and worse physical therapists, and some that you might like working with and some that you don't like working with. Just have you ever had, I'm sure there's lots of good experiences that you have, but have you ever had bad experiences where you're like, man, I really could have made a difference if I had seen this patient sooner? I guess maybe almost like, what do you wish physical therapists or other healthcare providers that are kind of outside, like your surgeons or your primary physicians, where you're like, I really wish they could know this about my practice, and I really wish they knew I could help this patient in this way a lot faster?
Yeah, so that's an excellent question. And first of all, I agree with everything that Erin said. And the key is to understand what the main problem that you're dealing with it is, right? So there's certain red flags that Erin talked about. If you can recognize those red flags and say, aha, this is something which is a little unusual, a little bit dangerous, let me just kind of send it over to a surgeon to get evaluated. As long as you can pick up on the red flags, you can treat a patient as a physical therapist, quite comfortably and quite confidently without causing any significant or long-term damage to that patient. So to answer your very broad question, I'll just kind of break it up in a couple of pieces. First of all, my experience with physical therapists is that as a profession, they're very, very they care about their patient very much. They're very professional, and they always want to do the right thing. And a lot of the physical therapists that I work with, that I communicate with all the time, but for regular patient care, they're very good about picking up on subtle signs and symptoms. Is the patient getting better? In that case, you keep on doing what you're doing. But has the patient kind of plateaued, and are they not improving over time? Well, then you may have to tweak the physical therapy a little bit better. And if for whatever reason, despite a consistent amount of physical therapy, just like Erin talked about, for 2, 3, 4 weeks, the patient's function, pain, and neurological issues are slowly kind of getting worse, then you have to kind of pick up on that red flag and send it over for a surgical consultation. The other thing that the physical therapists are very good about is they understand that as spine surgeons, we're very, very careful about making sure that we only operate on the patients who need an operation. And just because you send your patient that you've, had a long-term relationship with, you help them with their shoulder, their knee, their hip, and now they're having a spine problem. When you send that patient over to me, my goal is to see how I can help you as a physical therapist and kind of, take care of this patient non-operatively. Now, in the course of that treatment, if things are not getting better, then I'll be happy to kind of, discuss with the patient a surgical treatment. I also want to add that for the lumbar spine, we have the option of doing some injections, epidural injections, which can be very, very helpful. And I do some of the lumbar injections myself. And for some other type of injections, which I don't do, I will send the patient to like a pain management doctor, which is also an important component of spine care. So, the combination of physical therapy, medications, and kind of a close pre-surgical evaluation kind of over a longitudinal period of time, I think that's what most patients need. And fortunately, because physical therapists are very well trained these days, they're very good and diligent about kind of making sure that they take care of the patient in a very conservative but consistent way, so that hopefully they'll get better without surgery.
And this goes without saying, I'm a PT and Dr. Khan's obviously an orthosurgeon, but I believe in the beauty of utilizing PT. He also believes in surgery with other options as well. But especially if you're someone that's listening to this and you have low back pain, you don't have any of those options. Just do what works best for you. So we do dry needling, but some people have a great outcome with acupuncture. I know Dr. Khan has talked about that before in my communication with him outside of this podcast, but acupuncture, if you do Reiki, if you do massage therapy, anything that works for you, that's what you should do. Just because one person said it, again, you talk to your neighbor, you talk to the person at work, just because those people say that worked for them, you need to do this, doesn't mean you have to. You can always try it, but see what works best for you and what works best for your lifestyle and what's within what your means. And just try to, again, keep chipping away at your pain until you can get it to within a well manageable level.
I think what this is kind of shaping every time that I do have we have a guest on the podcast, I think it always comes back to, no matter what they're practicing, is that you do need kind of this healthcare ecosystem of knowledgeable providers for your whatever condition you're going through. So, in that case, it sounded like that you could have multiple different professions involved in kind of helping you through your spine pain. But ideally, in your eyes, Dr. Khan, you mentioned the pain management doc. What is the most common kind of ecosystem and group of healthcare providers that you see that patients need to utilize to have a well-rounded approach to approaching spine pain?
So, for the vast majority of cases of patients who have a back or neck problem, for example, like a herniated disc or sciatica or radiculopathy, a spinal stenosis, each practitioner can help the patient with a part of the problem, right? So physical therapists can work on some mobility. The acupuncturist can work on some cardinal points. The medical or therapeutic massage can loosen up the muscles. And the pain management doctor can do some cortisone injections. My job as a physician, as a surgeon, is to help coordinate all these aspects of care to make sure that each person is doing the best that they can for the patient. And if at the end that combined effort is successful, which it is about 9 times out of 10, then that's a great victory. On the other hand, for the 1 out of 10 times, or maybe even less than that, when all of that concentrated care by these different medical practitioners is unfortunately not successful, then I can give the patient a surgical option to kind of treat that problem. So this is sort of like the ecosystem, and as long as you understand that every member of this team can provide something valuable, in general, for the vast majority of patients, you can have a very good outcome with or without surgery.
And so I guess kind of a little bit piggybacking on top of that, there's the broader conversation of healthcare in general, and how the healthcare system is working with your patients and how you see patients. What is the one thing from both of your perspectives that if you could change about the way things currently work to make things better for patient care? Do you know what that would be?
I'll let Erin go first.
So I think the biggest answer I think everybody would want is more time. Like, if everybody could have more time spent with their patients, I think that is one thing I value so unbelievably. I just can't even put into words that we actually have at our facility, is like I do have one-on-one time with my patients for 45 minutes, which that's not too horribly common in the PT world, where you can actually utilize your insurance. Some places that are self-pay, you can utilize that, but for an insurance-based option. So I do get a lot of information from people in 45 minutes, either one time a week or 2 times a week, where I can ask all the questions I want to, as many open-ended questions during evaluation, but after you talk to somebody 2 or 3 times, you get all these small little pieces that they didn't think to tell you about. Oh, it really hurts when I do this, but I didn't think of it until now. And I'm like, well, that's probably what's one of the main instigating causes. Let's figure out a different way to do that. So trying to figure out how can we set up their home, like a small version of their home in the room we're at, and how can I modify, like how can I help you get on the floor to play with your kid or your grandchild? So truthfully, more time. And then I wish people would, or therapists in general, would be, we are physical therapists. We are not pain and torturous. Like people have talked about that term for the longest time. And I think so many people, on top of having a high fear avoidance behavior with low back pain related issues, then to think about going to physical therapy and having someone hurt you more. Our job is not to hurt people. If it hurts, it shouldn't hurt. And some things might be uncomfortable at the time, and you might feel a little sore after, but you shouldn't feel worse. Yes, there can be some days where it's a little bit more, but consecutively, each treatment after one or the other should not be extremely painful to where then you can't function. And I think I've seen that so many times, unfortunately, where patients will come in and like don't want to come, and they have such a negative feeling towards PT because when they did it before, all they did was hurt, or all they did was exercise the whole time. And in some back-related issues, a hands-off approach and emphasizing exercise only for certain people with certain backgrounds and medical histories, that is the gold standard to follow. But for some people, that's not the best option, and you have to utilize other things. So I don't love that about the PT profession, that people, especially I teach in a physical therapy program, and even some of the kids, like young students are trying to be really aggressive. I'm like, you don't have to push that hard. Just, you have to use your hands, you have to close your eyes, and you have to see what you're feeling, because you can feel a joint move without having to put your whole body weight into it. There is a total finesse that comes with a lot of the soft tissue work and the joint mobilizations we do, that you don't have to lay into somebody super hard and make them hurt for it to be beneficial.
And then Dr. Khan, from your from your point of view, what is, whether that's something with insurances, some way the hospitals work, what would make your life and your patient's life so much easier in the state of healthcare?
So that's a very big question, and I guess I could list 10 or 15 things. The biggest thing that comes to my mind is how expensive healthcare is and how stressful that is to a patient. So when a patient comes and sees me with, for example, sciatica, right? So you wake up one day and all of a sudden you have this burning pain going down your leg. You can't stand, and obviously you can't go to work. What do you do next? And not only are you dealing with a terrible physical problem, you're also dealing with employment. You're also dealing with the financial pressures. You're also dealing with now healthcare costs. And the healthcare costs, people's deductibles are sky high. And that's one of the things that shocks me is, if you have, family of, 4, for example, how high people's deductibles are. And in these economic times, taking care of your children and taking care of, household. And on top of that, you have to, put out, 4, 6, 8, 10 grand of your own money, just, outside of your insurance covered costs. That is a very big burden on our society. And something like, if my numbers are correct, something like 60 or 70% of all bankruptcies in the United States are healthcare related. So when I see a patient, with a spine problem, I'm always mindful of that. Even though I may not talk to them about it, I want to make sure that I provide them with very efficient care, good care, high quality care. But I want to send them to a place where they can get good care at a low cost, so that, they don't have the financial hardship because all of a sudden you can't work. And the second thing, which really kind of bugs me about how healthcare is practiced, is how complex and Byzantine the whole system is, right? Like the communication between different medical providers, different hospital systems, between the physical therapist and the doctor and the primary care physician, and all these different hospital systems and different providers have different electronic medical records. So there's a lot of difficulty with communication. So which is why it's so great that, whenever Erin and I have a mutual patient, we will just talk to each other about patient X and say, okay, well, let's speed up this process. This is working or this is not working. Let's change that. So I would say that, the biggest things that I wish were different with the healthcare system, number one was how expensive it is. And number two, how complex it is and how difficult it is to work within the system and make the changes that you need to make because of the red tape and the bureaucracy.
Hopefully that continues to get better. I know those are big topics and big issues to fix as a whole, especially in the US. So before we get going, I do want to talk a little bit about your YouTube channel. The Spine Surgeon Speaks. You can find that on youtube.com/Spine Surgeon Speaks. And can you kind of give us a little background on your channel and kind of what content people can expect when they go visit you?
So I have my own website, MustafaKhanMD.com, where I have some sample images of different types of surgery. So when a patient comes and sees me, I can show them what a C4-5 ACDF surgery looks like versus a lumbar laminectomy infusion, so they have an understanding of exactly what we're talking about. Also, when patients come and see me, they have Googled their condition to the best of their ability, and there's a tremendous amount of good information and there's a tremendous amount of bad information. So it's a whole bell curve. The reason I started my own channel was for patient education. So, for example, when somebody comes in and sees me for a sciatica or lumbar radiculopathy or a herniated disc, the conversation that I have with that patient is very similar to the patient that I saw, the day before and the day before that and the day before that. So my goal in getting my channel, Spine Surgeon Speaks, on YouTube was to basically condense that discussion in the form of a presentation that after seeing me, the patient can go home and watch that, 2, 5, 10, 12-minute video and kind of get a refresher. Another fact which is well known within the medical field is that when patients see a physician or a medical practitioner for a consultation, they have a limited amount of time, first of all. And whatever is discussed during that very brief 15, 30, or 45-minute visit, patient recall typically is very, very low. So when they go home and tell, their spouse, what was talked about or, the different things that were discussed and what the doctor said, unfortunately, because we're human beings, our memory is not perfect. So their ability to kind of remember that whole conversation and kind of remember the big points of that discussion are not as, it's not as good as it hopefully should have been. So I made this channel so I can have small bite-sized talks that, you can watch, whether or not you have a back or neck problem, or if you just want to get educated. And over a period of time, I want to build a sort of like a database of talks that people in our community and in the country and maybe even the rest of the world can kind of gradually come to as a resource. So I made my YouTube channel only a couple of months ago, like 4 months ago, and I don't have that many talks yet. But I'm constantly looking forward to adding to it. And whenever I give my patients my card with my YouTube channel, when they come back, they always tell me how helpful it was for them to kind of review that information after leaving that visit, so they're better prepared for their follow-up discussion. So my goal with my website, MustafaKhanMD.com, plus my YouTube channel, Spine Surgeon Speaks, is to serve as a kind of like an educational tool for the patients. And at some point, I also would like to kind of interview, physical therapists, acupuncturists, people from medical massage, and other different specialties to kind of add to this patient resource.
Perfect. And by the way, if you are listening to the podcast, you can find all the links to Dr. Khan's website and to his YouTube channel in the show notes. And if you're watching, it'll be in the description. So feel free to check those out below, and then utilize all those resources. I was watching a few of your videos before we did the podcast, and like you said, very informative, and the visuals are amazing in terms of being able to see exactly what you're talking about when you're doing those procedures, which I would imagine if you're doing those or if you're having that done to you, having a little bit of reassurance on what is actually going on, like you said, is very nice to have. So is there anything through our conversation that we missed and you feel like patients need to know before we get going? All set for the most part?
I'll let you have the first word there, and then I'll finish up.
I think one of the biggest things which Dr. Khan mentioned himself is, yes, spine surgeons, your job as a surgeon, but not every visit has to end in a surgery. So if you're scared to go see someone because you're scared to know what you're going to find out, it's important to know information at the same time. So we've been dealing with an issue for a long time. Just because you're going doesn't mean it always has to end in that direction of surgery. It might. Again, there's that percentage it will, but if you don't know and you've really been having trouble with something for a long time, it's not a bad place to start. And it's also great to have someone like that in your back pocket. So if you've had a history of, so if I have a patient that has a history of like multiple like disc injuries where they have irritation with a little symptom down the leg occasionally, but then it calms down on its own without medication, that's a person where I'm like, you should have someone like Dr. Khan in your back pocket. Like you should have someone you've seen, you've established care with. So if you do unfortunately get to that point where you need somebody, then you already have that. That takes that whole fear that what do I do next, that what's next step. It takes that confusion and that nervousness out of the picture. So you have someone to go to and you know who to see. Just like you have your dentist, like you get cleanings, but then you go there when you crack a tooth or you need a root canal. Hopefully you don't. But again, just like anything else, you have that person in your back pocket and they've already seen you, you've established care. So when you have that incident happen, you can go see them a lot faster because you're not a new patient. And that can be very reassuring if you have one of those instances where you wake up and can't get out of bed or you can't sit because your sciatic symptoms are so bad. So sometimes having that already established care can be really helpful.
What I will add to this, it's kind of a little bit philosophical. First of all, I feel so honored and privileged to be in a position where I can be where I can help people. And that's not just a cliche. When I do my surgeries and I look at the inside of the human body, I'm just truly humbled and just always in awe of how amazing the human body is and how when it functions, we take it for granted. And when even a small piece of it, like a tiny herniated disc, which is about the size of a pea, when something that tiny breaks down or pops out of place, how incapacitating it can be for the whole organism, for us as a person. So there's just an unbelievable amount of just beauty and elegance to the human body, which as a surgeon, whenever I look at it, I'm always in awe. And I feel very, very blessed, fortunate, lucky to be able to kind of tweak it a little bit to make it work better. And having done thousands and thousands of surgeries, every surgery that I do, my level of wonder, it does not go down. It actually goes up more and more with every year. Because I see what a finely tuned machine the human body is and how important it is for us as human beings to take care of ourselves, to make sure that we take care of our general health. We make sure that we take care of our physical health, our mental health, and we do everything within our power to have just a good life. And this is where, Erin and I come in. Erin will help the patient in one way, and I can hopefully help the patient in a different way. So I'm just very privileged and honored that I can do that for my patients, and hopefully I'll be able to do that into the future.
Well, it's certainly been a privilege and an honor to have you on as a guest, and it's been really good having a conversation with you and Erin as well. So thank you both for coming on. And like I said, Dr. Khan practices in the Milwaukee and Mequon, Wisconsin area, and you can find his website at mustafakhanmd.com. That will also be in all of the show notes. So thank you so much, and have a wonderful day, and thank you for coming on our show.
It was my pleasure. Thank you, Brady. Thank you, Erin.
Yeah, thank you.